tell me what time to start.
I think it's okay to start.
Okay, very good. So everyone, welcome to our every 2-month meeting that we call the Q2M. And we are absolutely excited to start the year, with the presentation that we are going to have. And so this is our group. This is a supportive care network, and it is a fantastic network within SIOP that we are here to assure that our colleagues, oncologists, and other people who work very closely with pediatric cancer, so they are completely successful in assuring survival of cancer. So just to share with you, this is the group of leaders who are leading this network. And here you have Pia, and there you see her. So she's waving, and so she is the co-chair. And together we lead the SIOP supportive care network. And of course, we have our fantastic steering group. And you could see down below, you see Jess Morgan from the UK, Gita Nadu from South Africa, Arpita Bhattacharya from India, Jocelyn Rivera, she's from Mexico, Sadaf Alta from Pakistan, and Maya Prasad from India. So we are very honored to have this amazing group of professionals with us. And I put in dark pink those that join for the next period. And so they are Gita, Arpita, and Jocelyn. So thank you so much for your generosity and giving your time and your expertise to really support this network. And of course, we have Adam Espenshade. He's a liaison with us with other group. And thank you so much, Adam. You have been fantastic also supporting us just to assure that we maximize the use of expertise and effort so that our little one got a chance to survive. All right, so some very exciting news. This is the SIOP Annual Congress 2025. This year is going to be in Amsterdam. And so the abstract for poster has been is open. And so please consider submitting this. And I think that the deadline is going to be in April. And so the abstract welcome from everyone from and if you're not using the mic, would you please mute that? So the abstract are welcome from everyone, from members and non-members. And so, and again, SIOP members say up to 300 euros on Congress registration rate. So please start taking a look at your amazing research that you would like to share in this forum. And I'm telling you, this forum is incredible. So I'm very excited about that. So the other very important part is to have access to all these amenities and resources and opportunities of collaboration. It is having a membership. So remember just to go ahead and renew your membership. And again, I need to remember myself, always just to make sure that we are all connected. And again, then take a look at also all the opportunities that you have, and especially eligibility for SIOP scholarship and awards. And now we normally have like every other meeting with the entire group, an expert that come and talk to us about important topics in supportive care. And what a topic. And this is vascular access. And we know that modern medicine cannot really be practiced without having a secure and reliable vascular access. But as such, vascular access has its own complications and issues. And so Lauri Linder is coming and she's going to talk to us about that. So now I'll take the opportunity to introduce her. So Lauri, she's a professor and chair of the Division of Acute and Chronic Care of the College of Nursing. She's an adjunct professor in the Department of Pediatrics at the University of Utah. And again, she devoted a lot of her career in to understand better about vascular access, and importantly, to find ways in which this the use of this device is more safe. So her topic is going to be infection prevention and control and vascular access. And these are the objectives. So this webinar will discuss common type of central venous catheter during the care of children with cancer and consideration when selecting a venous catheter. Then also she will be addressing in this webinar maintenance and care consideration for optimum care of children with cancer with central venous catheter. So welcome, Lauri, and again, very, very thankful for giving your time and your expertise, sharing your expertise with this audience. And so I'm going to stop sharing, and if you can share your presentation.
Yes, thank you, Miguela. I'll be happy to do that. Just give me a moment here. We'll share.
And if you have questions, I'm going to be taking a close attention in the chat. And so I'm happy to moderate that. And again, Pia also is there, who's going to remind us of any other thing going on. Thank you.
Okay, can you please confirm that you can see the slide
Yes, we
presentation
see.
as it should be?
Beautiful.
Okay, I apologize. I'm getting over a virus and I hope I don't cough too much during this presentation. But thank you all so much for being here with us. And I hope that this will be useful to you just as you think about how you might choose a central venous catheter for your patients, and then also how we consider the maintenance care of these devices so that we can give safe care to the patients we serve. I have no industry related relationships. I'm not going to be directly sharing some of my past research with you, but I did want to acknowledge a couple of the sources that have funded different research projects in the past that I've done related to the care of central venous catheters and infection prevention. So as Miguela said, we're going to be talking about some common types of central venous catheters used in the care of children with cancer, and also just some general considerations when you're selecting a central venous catheter, as well as I'm going to put a fair bit of emphasis on the maintenance care because again, like I said, we can put these lines in, but at the end of the day, what really matters is that we can manage these lines safely, keep them in place over time so that our children can receive the care that they need. Just by way of introduction of myself, I'm based in Utah in the United States. I've highlighted Utah there in the red. And our hospital serves a multi-site, multi-state region. So we're fairly sparsely populated here in what we call the Intermountain West of the United States. So even though we're centered in northern Utah, a number of our patients come from fairly remote areas. And so for us, being able to make good decisions about the types of lines that we place in our patients and then support them with the care that they need is very crucial. And we have a number of home health agencies or access to those services here. So partnering with them is very important. So I think it's probably well known to all of us here that central venous catheters are important in the overall supportive care that we provide to our patients, whether for giving intravenous chemotherapy, the blood product transfusions, giving parenteral nutrition support, and then a number of our patients end up receiving IV antibiotic therapy. So we need a good, reliable source of vascular access to be able to give all of these cares. We can think about the different types of central venous catheters as being either temporary or permanent. And when I say permanent, it really means longer term, because we certainly don't keep these lines in our patients forever. But our temporary lines could be a non-tunneled central line. These are more commonly used on a short-term basis in an intensive care unit. So generally are in place for a few days, sometimes a week or longer. PIC catheters, those peripherally inserted central catheters, those are, more temporary, but we do use those fairly frequently in pediatric oncology. In our United States settings, the most common types of lines that we place are these permanent or long-term lines, whether they are the venous access ports or a tunneled central venous catheter, and we'll be talking about each of these in a little more detail. So I'll talk about our PIC lines, or these peripherally inserted central catheters, first, and you can see that from the illustration here that they're often threaded through a cephalic, basilic, or brachial vein. The tip typically terminates in the distal superior vena cava. One of the benefits of these peripherally inserted lines is that they don't have to be placed in an operating room. They can be placed by individuals with specialized training, and in the United States, often that's a nurse who has received that additional training. And we often do these PIC placements as sedated procedures. So if your center is inserting PIC lines, you do want to think about, do you have the resources in place for sedation and for them being able to monitor that patient safely? One of the nice things about PICs is that they can be in place for several weeks to several months. They do require daily maintenance care, so that is something to consider. So not a problem if the patient stays in the hospital, but if that patient is going home, you want to make sure that you have access to resources who can provide that daily maintenance care. We do have double lumen PIC lines that are available, so that is something to consider if your patient does have more complex supportive care needs. We do have PIC lines that can accommodate power injection of contrast for a medical imaging scan. We'll be talking a little bit about that later. And one of the nice benefits of PIC lines is that they can be very easily removed if that line is no longer needed, or if it needed to be removed in the case of infection, or if it wasn't functioning properly. Now, implanted ports are probably most widely used for vascular access in our patients with cancer here in the United States. These do require surgical placement, and they have to be removed by a surgeon as well. So that's something to think about if you want to use this type of device. How quickly do you have access to surgical services if that line were to need to be removed in an emergent scenario? The nice thing is that these ports can be in place for months, even years. They do require access with a non-coring needle, so that's a very specialized type of needle for use with these ports. It has to be replaced every 7 days. One of the benefits of ports for our patients is that if the port isn't accessed, the families don't need to provide any type of daily care for the line. So that makes it a really attractive option for a number of our families. Some ports are what we call power injectable, so they can be used to inject contrast for a medical imaging scan. And we do have double ports. So that would mean that the device has two of those septums attached together. And for some of our patients who have more intermittent but complex types of chemotherapy being administered, some of our families appreciate that option. And then we also have our tunneled central venous catheters. These are surgically placed. It is possible to remove these at the bedside. If they were to be removed at the bedside, you'd want to think about having a little bit of a local anesthesia with those, and because it can be a little more complicated to remove at the bedside, but it can be done. These lines, like the implanted ports, can be in place for months to even a year or longer. They do require daily maintenance care, so that is something to think about. Power injectable tunneled lines are available, and multi-lumen catheters are available. So then moving on, as we think about caring for our patients with central venous catheters, I'm going to be talking about things to think about when selecting and inserting a central catheter, maintenance care. I'm going to also talk about nurse staffing and training. I don't know if we have any nurses on this call. I hope we do. But even if we don't, I'm hoping that you all can come away really thinking about how you might advocate for supporting the nurses who are managing these central venous catheters. We'll talk briefly about common complications, and then also talk about ongoing surveillance and quality improvement initiatives that you might want to consider at your places, just to make sure that you are giving safe care to your patients, and considering how you can consider other options for ensuring quality care. So with that, just as you think about selecting the type of central venous catheter that your patient might need, you do want to think about factors related to the patient. So how big is that patient? Some of our very small patients just aren't big enough to have a port placed, although we have placed ports in toddlers before. You want to think about the vascular anatomy of your patient. So is one type of line going to be more difficult to place than another? Also consider the tumor size and the location. Sometimes our patients, excuse me, who come in with large mediastinal masses may not be able to tolerate going to the operating room to have a port or a tunneled line placed early in the course of their diagnostic evaluation. So those patients may benefit from having a PICC line, and then as that mass shrinks in response to therapy, then that patient could tolerate having a surgical procedure to have a port or a tunneled line placed. You also want to think about treatment-related factors. So how long is this patient going to be receiving therapy? For some of our patients with shorter term therapy, so some of our patients who are only receiving therapy over 3 months or less, we may be able to keep a PICC line in place for the duration of that therapy. For other patients with longer term therapy, we tend to opt for the longer term catheters. You also want to think about anticipated supportive care needs. So based on the type of therapy, will that patient likely need multiple blood transfusions? Do you anticipate some complex pain management needs where that patient might need to have continuous IV pain medications? Also, think about the types of medical imaging scans that your patient might need. So, if your patient is going to be having frequent medical imaging scans, such as CT scans, where there would be a need for CT contrast to be injected, that contrast is power injected. So if you might want to consider a power injectable central venous catheter if that's available at your facility. If not, then the patient would need to have a peripheral IV placed for that contrast. So certainly either option is fine, but that's just something to think about. You also want to think about the system and the larger infrastructure where you're practicing. Do you have access to home health services who can provide daily or support families with providing daily maintenance care if you were to send your patient home with a central venous catheter in place, say a PICC line or a tunneled central venous catheter? You also want to think about access to surgical services. So if you did place an implanted port, um, if that patient were to develop an infection or a complication related to that port, do you have access to surgical services who could remove that port if needed? And we say as a general rule of thumb to use the catheter with the minimum number of ports or lumens necessary for the patient's care. So if you anticipate that a single lumen device is going to be adequate for that patient's care, then just insert a single lumen line. Don't insert a double lumen line just because it's available. And then I'm going to be also sharing some recommendations from our Centers for Disease Control and Prevention here in the United States. This group has put together a number of different recommendations related to catheter care, whether it be the insertion or maintenance care, with the goal of preventing infection. So at the time of catheter insertion, whether it is a PICC line that's being placed, say at the bedside as a sedated procedure, or insertion of a port or a tunnel line in the operating room, they recommend having maximal sterile barrier precautions in place. So that means that the person inserting that line is wearing a surgical cap, has a mask, and gloves, as well as a drape just to protect that field. We always say hand hygiene before and after. That's central to any type of infection prevention. Making sure that the skin is prepared with an appropriate antiseptic solution, often a chlorhexidine with alcohol mixture. If that's not available, then tincture of iodine or a 70% alcohol solution would be appropriate for prepping the skin. Current recommendations are to use ultrasound guidance for placement if an ultrasound device is available to you, and then to be sure to verify the catheter tip position prior to use. Recommendations are generally to position that tip at the cavo-atrial junction. I've starred that on the image here. Otherwise, you want it to be in the lower third of the superior vena cava. So then once that line is in place, really the bigger challenge is to provide rigorous maintenance care to keep that line in place and to prevent against complications. And we think about maintenance care in the context of what we call bundles. Bundles are just refer to standardized evidence-based practices, so a group of those practices that are really aimed at overall improving our care processes and patient outcomes when we implement those consistently. So that's kind of the key with as we think about maintenance care bundles is those group of processes and then implement those consistently. And those include daily discussion, daily assessment, thinking about central line entries, dressing changes, and then tubing and needleless connector changes. And I'll be talking about each of those. So as we think about daily discussion, this daily discussion should involve the interprofessional team. So whoever is doing rounds or providing care to that patient that day, so whether it's physicians, trainees, we absolutely want to make sure the nurse is part of these daily discussions. And those daily discussions should think about, do we still need this central venous catheter for providing care to this patient? And if not, let's talk about, can we remove this line? Now, granted, most of the time in pediatric oncology, we need these lines over weeks to months of care, but we still want to be thinking about, do we need this line? What is the appearance and the function of the line? So does that site appear as we would anticipate? Is it becoming more inflamed? Let's talk about the function of the line. Does it flush easily? Does it return blood? Do we have any concerns about its patency? Do we have concerns that maybe its position isn't correct? But we want to be discussing those every day. We want to be thinking about, how often are we using this line? And we'll talk about ways that we can think about reducing some of the number of the times we access that line every day. We want to think about, are we giving IV medications that we really could be giving orally? So we want to use that line for the right reasons, but if there are things that we're doing, such as some of our IV supportive care medicines that could be switched to oral, let's think about that. We also want to think about, can we consolidate when we are obtaining laboratory specimens through that central venous catheter? So are there multiple labs that need to be drawn that day, but could we do them all at the same time? So with that, let's talk a little bit about that daily assessment. And as we think about the daily assessment, that includes the appearance of the site, and really, and the condition of the dressing goes kind of go hand in hand there. We want to think about but with that site, again, are we seeing evidence of any erythema, any concerns about infection around the site, and even the area covered by the dressing? Do we see evidence that maybe that line has become malpositioned? So if it's a tunneled central venous catheter, do we see evidence that the cuff on that catheter might be coming out, which could give us cause to worry that the line isn't in place? Is that line patent? Again, does it flush easily? Does it return blood easily? What's the condition of that dressing? Is it occlusive? Is it secure? And is it soiled? If it isn't secure and occlusive, we need to be thinking about changing it. We'll talk about the dressing later. And as part of that daily assessment, that person caring for the patient should know, okay, do we have documentation of the most recent dressing change? If it's a portacath, do we know when that port was most recently accessed? Do we know when those needleless connectors were most recently changed? Do we know when the tubing was most recently changed? We should know those things. So talking about central line entry, so this would just be when we access that line to give a medication, administer a blood product, draw a lab specimen, whatever it is. Good care starts with hand hygiene before and after working with that central line. You want to make sure that you are disinfecting that needleless connector before entering the line. General rule of thumb is to what we call scrub the hub. So use whatever solution it is, whether it's an alcohol pad or a combination alcohol and chlorhexidine pad, but give that hub a good scrub for 15 seconds and then allow it to dry for 15 seconds. And that just allows that provider, whoever is working with the central line, to just kind of stop focus on that task at hand and not be distracted by other things when providing central line care. And then we also want to think about how we can consolidate line entries whenever it's feasible. Sometimes the required timing of line draws is such that they can't be drawn at the same time. But again, think about what are things that we can consolidate. Certainly if the medication has to be given intravenously, give it intravenously. But if it's something that could be easily switched to oral and the patient can tolerate it orally, let's consider that. So next, when we think about maintenance care, we want to think about dressing changes. So again, wearing gloves, wear clean gloves when taking off the old dressing, wash hands, put on sterile gloves to do that new procedure, to replacing the dressing. Make sure that you're cleaning the site, the insertion site, with a chlorhexidine solution. Unless the patient has an allergy, then use an alternate. Our general rule of thumb with dressing change frequencies is if you're using a transparent dressing, and that's what's illustrated here in this picture, to change that dressing every 7 days. If it's a gauze dressing, then to change that dressing every 2 days. Again, we want to be really thoughtful about avoiding distractions during that procedure. If at all possible, have a dedicated clean surface that can be used for holding the supplies. We'll talk about some strategies for that. And then also, if you have a patient who the dressing tends to become loose rather easily, reinforce that dressing at the time that it's placed to keep it occlusive. If that dressing is becoming loose, if it's wet, gets wet, if it's visibly soiled, then you want to make sure that that dressing is being changed promptly, and don't wait until 7 days have passed when it would otherwise have been due to have the dressing changed. And that's part why that daily assessment is so important. Just making sure that we have an intact, secure dressing to protect that site. Now, with implanted ports, as I mentioned, they do require access with a specialized needle that's been designed to access that port. Do consider the need for what we would call a topical anesthetic, so EMLA cream, or a vapocoolant spray. Again, cleaning that insertion site. Once that needle has been placed, cover the site with a transparent or gauze dressing. Our general recommendation is to change the needle every 7 days if that port remains accessed. Again, avoiding distractions during the procedure, and then replace that needle and the dressing if the dressing were to become wet, soiled, or loose. Needleless connector changes are, you want to disinfect that connection site before the old connector is replaced. Routine change is generally no more than about every 72 hours. And then if blood cultures are being drawn, replace that connector before obtaining blood cultures. Some other practices that can be helpful as you think about some of these practices related to maintenance care would be to advocate with your facilities to provide your nurses with what we call kits, or a packaged group of supplies that are necessary for whatever care is being provided. In these first 2 illustrations, I have pictures of a dressing change kit. So it contains all of the supplies that a person would need to change the dressing, so the person changing it doesn't have to gather all of those supplies independently. Just by gathering that kit, the person knows that I have all of these supplies together. And then I also have a picture of a metal tray that we've used here at our facility as just a clean, dedicated surface that the nurse can bring into the room, set out all the supplies on that, do the procedure, and then after that procedure, clean that tray so that it's ready for the next person. We want to secure the dressing and the catheter at the time that the dressing's placed. So if that dressing is already becoming loose, you don't want to replace it then, but or reinforce it rather. If the dressing were to become loose, you'd replace it. But secure that line where it's exiting the dressing. Consider a stabilization device. So these are some pictures of some other things that are on the market that can help keep that line secure so it doesn't get pulled or dislodged. And you also want to be really careful with how the ends of those catheters are placed. For our young patients who have diapers, we want to keep those away from the diaper. Oh, okay. Oh, I already had the securement part on this one. I apologize for not removing that slide. Flushing practices, generally, we want to use a 10 mil or larger syringe to avoid extra pressure within that catheter. We really don't have definitive recommendations about whether it's better just to use saline alone, the volume of saline, or the frequency of flushing. The general principle, though, is to flush the line with what we would say is twice the catheter volume, using normal saline after each use. That's going to be approximately 3 mils of saline, or at minimum, at least daily. If your site is using heparin, use a 10 unit per mil of heparin for routine flushing. If you're deaccessing an implanted port, at that point we say to use 5 mils of 100 unit per mil heparin. So let's talk a little bit about some of the common complications that we might see with central venous catheters. I want to be mindful of time. Bloodstream infections are one of the big complications that we're all very mindful of, just multiple ways that organisms can enter the bloodstream of our patients, whether through breaks in the skin, having that catheter hub being contaminated. So we want to be extra vigilant with our care practices. Certainly, with our patients who are getting mucositis, anywhere along that GI mucosa throughout the upper and lower gastrointestinal tract, it's easy for organisms to cross from injured mucosa into the bloodstream. So we want to be really thoughtful about identifying infection quickly and being vigilant with those maintenance care practices to help minimize that risk of infection. Certainly with our patients, we know prolonged hospitalization is a risk factor, as are our hematologic malignancies, patients with relapse disease, those getting steroids, any of our patients with prolonged and profound neutropenia, and those with injured mucosal tissue are much higher, have a much higher risk for infection relative to our other patients. Just with infection management, we want to be sure to get blood cultures with that first fever. If other sites are suspected as being as sources of infection, get cultures from those sites as well. Initiate IV antibiotics promptly. Monitor our patients for signs of sepsis, be prepared to respond and escalate to a higher level of care if necessary. And then also consult with infectious disease teams. In some cases, we can just treat that infection and keep the central venous catheter in place. In other situations, if those blood cultures are persistently positive or based on the organism that's present, the better choice might be just to remove that central venous catheter. So other complications that can arise are occlusions. So if an occlusion were to develop, I'll share in just a second an algorithm for determining the potential source of that occlusion. So based on the circumstances at the time, it could be either a fibrin clot, it could be a chemical clot from what is infusing at the time. In those cases, we do want to treat with the appropriate clearing agent. We may need an imaging study to evaluate proper placement of the line to verify that the line is in place, or if perhaps it isn't. And then the line may need to be removed or replaced. Again, we may need dislodgement is another complication. In that case, we would need an imaging study to evaluate placement. At that point, we'd need to confer as a team to determine, well, how far out of place is this line? Is the better choice to remove it? Do we feel that we can safely continue to use this line? Occasionally lines can break. In that case, we want to be sure to clamp that line proximal to that break and then determine, do we have the resources to repair this line? Some of our because of the materials used with some of our power injectable PICCs and tunneled lines, those lines can't be replaced if they are repaired if they're broken, so they would need to be replaced. This is just an algorithm for managing catheter occlusions. If anyone wants these slides, I'm very happy to share them, but just goes through that process of thinking about, well, what might be the cause of that catheter occlusion? What were the circumstances at the time that that line was no longer patent? Do we suspect a mechanical occlusion? Do we suspect that it's a fibrin sheath or thrombotic occlusion? Or could it be a chemical occlusion? And then this slide walks you through ways of thinking through the appropriate clearing agent. If that's successful, if it isn't, consider whether you repeat that clearing agent. And then if that isn't successful, consider whether or not the line might need to be replaced. I did want to spend some time talking about quality outcomes because in any of our places, whether we've been caring for patients with central venous catheters for years and years, whether we're newer to having central venous catheters available for our patients, we do want to think about those quality outcomes. So are we able to maintain our lines in place for the desired period of time for the patient's treatment? Are we providing best practices related to the maintenance care of these lines? Do we have opportunity to provide even better care? What are our complication rates? And how can we improve those complication rates? And this is also a way that you can advocate with your facilities to help you have the data that you need to be able to determine, are you providing the highest quality of care possible to these patients with central venous catheters? So you want to think about who should be part of your quality team. So often we think about our infection prevention team. We want nurses involved in our quality improvement teams related to the care of central venous catheters. We want physicians involved because every one of those team members has a responsibility. You want reporting processes. We'll talk a little more about that. And resources to support audits. So can you audit the care that you're giving to make sure that it aligns with best practices? You want to work with your facilities to advocate for your being able to have relevant data related to central venous catheters. So do you know the number of central venous catheters that are placed in a given month or year at your facility? Do you know the number of central venous catheter days that you have? If a patient develops an infection or has a line occlusion, do you get that information so that you know how many infections are happening on a monthly or annual basis? And do you have a way to evaluate your adherence to these best practice bundles? And, here's also where I like to give a good shout out to our SIOP baseline nursing standards. These were developed, over 10 years ago now by a group really looking to say, well, what are some of these baseline expectations that we should have for nurses, primarily in low and middle income countries? But these baseline nursing standards really are relevant regardless of the setting as we think about the care of patients with central venous catheters. So are we staffing our units appropriately so that that nurse has time to assess that line as they should, and that the nurse can be free of distractions when providing central line care? Are nurses getting formalized orientation and continuing education in the care of central venous catheters? Do we have multidisciplinary teams that include the nurse in the discussion of the line, whether it's each day or as you're thinking about larger quality outcomes for your practice setting? Do the nurses have access to resources to provide safe care, whether it's, supplies bundled in a kit, a dedicated work surface? And then do they have evidence-based practice documents or procedures in place to guide the care of patients with central venous catheters? And I've listed the website there where you can learn more about these baseline nursing standards. So as you think about ensuring that your nurses are equipped as best as possible, do they get central line care in their orientation and continuing education? So we like to recommend, do they have a chance not just to learn about central lines, but do they have time to practice the skills as part of their initial orientation and then in ongoing orientation? And do you use skills checklists? So not just, well, do they know how to do these cares, but do we have a skills checklist to guide that whoever is providing that central line care, are each of those steps followed to provide safe care, whether it be for central line entries, routine assessment, dressing change procedures, port needle access and deaccess, and changing those needleless connectors on the ends of the central catheters. We recommend that your facilities have some type of written protocol related to each of these aspects of central venous catheter care. So routine assessment and care, the procedure for doing a dressing change, obtaining blood specimens, doing the needleless connector and tubing changes. And do these documents have evidence-based references to support the practices? So not just naming steps, but are those steps supported by current evidence? And also, do your written protocols have the expectations for documentation? So not just the psychomotor steps of care, but then what gets documented? And are these protocols in a place where they're easily accessed by the nurse so that that nurse can access those whenever they need to provide central venous catheter care? Some recommendations regarding documentation. So that documentation should include expectations about routine Central venous catheter assessment. So that documentation should say, what was the condition of the site? Is it patent? What's the integrity of the dressing? It should be clear when anyone is referencing the documentation for that patient, the date and time of the most recent dressing change, needleless connector change, and tubing change. What is the length and gauge of the needle that's used to access an implanted port? And then when was that line most recently flushed? And then what was the volume and concentration of solution that was used? Let's see, go forward. As you think about quality outcomes to monitor, as you think about information you want for each central venous catheter, can you get the date that it was inserted, the type of catheter, what was the reason for its insertion? You know, for most of our patients, it is to support chemotherapy and the related supportive care. What was the date of removal? Because if you know the date of insertion and removal, you can track the number of catheter days in your facility. What was the reason for that line's removal? Was it simply removed because therapy was completed, the line was no longer needed, or was it removed because of a complication? You want to be able to document complications and dates of complications so that you have a sense of, you know, how frequently are patients developing infections? Do you see a recent clustering of infections? Can you tie that to adherence to maintenance care bundles, for example? So see if these are just, this is data sources that you want to leverage access to with your institutions. And then as you think about measuring adherence to bundles, this is a great opportunity for nurses to get involved in quality improvement processes. So when you think about measurement frequency, it really is going to vary based on that outcome that you want to measure. You know, does it make sense to, are there things you want to measure on a monthly basis? Things that you want to measure on a weekly basis or with each occurrence? So maybe if you were had a new group that was learning how to place PICC lines, maybe you want to have an adherence checklist that you could monitor adherence to those best practice guidelines each time a PICC line is placed. In other cases, you might want to monitor 10 dressing changes a month or something. You think about what makes sense for your setting. And then again, with your measurement approach, do you want to do some direct observation of the staff performing the care? And then think, do you want that staff member to know that they're being observed? Or do you want someone to observe without letting the person know that they're being observed? Or do you want to look at documentation in the medical record? But really thinking about however you're choosing to measure, do that with the goals of really looking at catheter-related outcomes. Goals of measurement can help you identify needs for staff education or re-education, prioritize areas that might need improvement, and then also to help you think about, well, are there new interventions that we might want to implement to improve outcomes? So just in summary, we all know that these catheters are important to meet the supportive care needs of our patients. Best practice care bundles can reduce the risk of infection and other complications. Comprehensive nurse training aligns with SIOP's baseline nursing standards. And then multidisciplinary teamwork is essential for ongoing quality improvement to enhance the care of children with central venous catheters. And with that, what questions do you have? My final slides are just some references, and we can pass those along to you as well. So I will stop sharing.
Thank you so much, Lauri. That was very comprehensive, very nicely presented, very practical. And just very quickly, just to tell the audience that the recording is going to be is published in YouTube, and this and Susan put there the details of that, and so this is going to be if you want to find it, it will be in the SIOP YouTube channel, and this is www.youtube.com/world_SIOP. And so anyways, thank you so much. So here, Arpita Bhattacharya, she is from India. I'm not sure, Arpita, if you want just to unmute your microphone and just briefly mention that, or you want me to?
Hello.
Hello, yes,
We can
Arpita.
hear you. We can hear you.
Okay. Thank you. That was a lovely presentation. Thank you so much, Lauri. Unblocking agents like urokinase have not been available in my country for more than 3 years now. And sometimes with just persistence and gentle heparin locks, we manage to unblock. But I know, and all of my colleagues know, that it is quite useless as far as tough blocks are concerned. I think that urokinase solutions, dilute urokinase, 1 in 25,000 solutions, should be on the SIOP essential drugs list to convince governments to make sure that their supply is uninterrupted, because it's very expensive putting in lines in LMICs. It's a big investment. And if we lose a line because of blockage, it's a terrible thing.
Yes.
Thank you.
We have, thank you so much, Arpita. We have also from Mihra Galib, and I'm going just to quickly read because we have very short time left. And so she talked about PIC, and for patients who need anesthesia during radiotherapy, we use PIC. How frequent the catheter should be changed? Is that okay every 3 days?
Okay, Mithra, are you talking about the entire PIC line, or are you talking about the dressing or the connector on the end of the line?
No, the PIC one. Because, a patient go at your hotel, it's not always at a hospital. So is there any special care, or is that okay just for changing the catheter, the PIC every 3 days? Because if I'm not right, it should be changed every 2 days.
Oh, yes. Okay, I see what you're saying. So the dressing on that PIC line.
Not only the dressing, but the PIC, the catheter, the catheter itself. We should change it. How frequent we should change it, the catheter?
Most likely is the connection, is right? Because normally the PIC line can stay for a very long time. Yeah. Most likely it's the connection. So if you can answer very quickly that, so we can pass to the next.
The connection would be fine every 3 days, and even the dressing, the dressing would be fine every 3 days if it's a gauze dressing. We don't really have evidence that 2 days is better than 3 days for the dressing.
And
Okay.
Jocelyn from Mexico is talking about in case of DIVA patients, what would be catheter recommendation considering a patient receiving chemotherapy, frequent blood? Okay,
Can you tell
so
me what
the
you mean by
type of
DIVA?
Yeah, I don't know what is that, but most likely it's going to be a patient receiving a frequent chemo and blood sample, what kind of catheter the patient.
Yeah, I mean, that will depend some on, is the patient going to be going home?
Sorry, I'm Jocelyn. I meant about those patients with difficult access. Sometimes in my
Oh,
hospital,
yes.
this has been the sole reason to place a catheter, because they are hard to take samples, they are hard to have IV access.
Right. So I would think, either a PIC or a port would probably be be a good choice. I think, as I mentioned earlier, it's going to, in some way depend on what type of surgical services you have, with ports. If that port were to have a complication, could someone remove that port promptly? With PICC lines, they do require daily maintenance care. So you'd want to make sure that if you were sending the patient home with the PICC line in place, that the family has access to the resources to support daily care of that PICC line.
All right. Well, thank you so much. And so I think that we are getting to the top of the hour. If you can give a very quick answer to the last question. Not sure if you can read that. Can you read that?
Okay, this says, I saw there was some research about the need for sterile dressing care. Do you have information about that? In some ways, that is a bit of an unresolved issue. I know in the US, we try to complete the routine dressing change as close to a sterile procedure as possible. But I know in many of our home care situations, we really teach our families and the home care companies about doing a good aseptic clean technique. Really going to be important to use good hand hygiene before providing that doing that procedure, ensuring that there's a clean, dedicated field for having the instruments and the supplies set out on that. Had some cases that we used a clearing agent, but the access remained blocked. You sometimes use a 24-hour clearing, and what are next steps? I know sometimes these can be, unblocking lines can be challenging. Sometimes we've, I'll say from a practical experience, I don't know if this is totally absolutely evidence-based. I know I've had some situations where we, tried the clearing agent. After half hour, an hour, it hadn't cleared. I have reinstilled, sent the patient home with that line marked. It's like, don't use the end of that line. The patient came back the next day. We were able to clear at that point. But I know some of the more difficult occlusions can be challenging.
Right. So also there is talk about protocol age specific regarding catheter type. And I think that there is a publication about that. I don't remember right now. Anyway, so said that, I just wanted to conclude this, and thank you so much, Lauri. That has been fantastic. And thank you everyone who came. And so just, I'm going just to go ahead and just share some, very quickly, some closing remarks. And that way everybody can get to go to their next engagement. So these are the calendar for the year. So today is the 16th. The next time we are going to be meeting is going to be in March the 20th, and then May and July. So the next talk is going to be May 15, and the following is going to be in September. But we are going to be meeting every other month. And you could see here in October is going to be SIOP. Anyway, so Pia, I'm not sure if you want to mention anything else. Thank you very much. And these are the flowers for the month of January for those who love flower. So you take care, and thank you again for coming, and thank you, Lauri.